All right. Good afternoon, everybody, and thank you for joining us to the NRBS webinar that's going to be led today by, we've got with us Michael Holler, and he's going to be talking to us about working with OCD using bioregulation therapy. This is sponsored by Nesta, Bioreg Technology, and we also have with us the president and owner of the company, Tarul Sengul. It's been nice chatting with him a little bit, learning more about their products. I mean, if you get a chance, you'll see in the chat we're going to include a link to their website that you can visit them, learn a bit more about biofeedback and pulsed electromagnetic field technology. They've got a lot of great products that you can look at that would be considered really good complementary kinds of tools, things that you can use to enhance your practice with neurofeedback. So we recommend them and thank them for their patronage and supporting us on this. So before we get jumping into the fun part of learning from Michael, we're gonna talk a little bit about NRBS, the Northeast Regional Biofeedback Society, and kind of keep you up to date with some of the things that are going on. I should say my name is Jeff Schutz. I'm one of the recent additions onto the board of directors for NRBS and have the privilege of being able to moderate this session. Keep in mind, we've got upcoming the Connect Tuesday, where we'll have a 1 hour interactive conversation with folks. Our next topic is going to be April 1st at noon. I believe it's 12 o'clock, correct, Ronnie? And the topic of this is going to be technological advances, AI, and wearables. So we encourage you to come on in, learn a little bit more about that topic. Also, keep in mind, we're going to continue with our webinar series. Our next webinar is going to be sponsored by BioSource Software. That's going to be on April 27th. The presenter is Fred Schaefer, talking about improving client care by dispelling breathing myths. So that's coming up on April 27th. We also have, we're going to have the podcast, Healthy Brain, Happy Body, which is hosted by NRBS board member, Dr. Saul Rosenthal. And he's going to be continuing with today's conversation, the conversation from this webinar, addressing unanswered questions, diving deeper into anything else that maybe we didn't get to or questions that you may have had. So for each one of these things, as we talked about that Connect Tuesday, the next NRBS webinar, the podcast, all of the linkages and the connections, you can find that in the chat. I also want to encourage you to, if you are not already a member of the NRBS, we'd love to invite you into membership with us. It's been my privilege to join this board. One of the things that I really love about this group of individuals for neurofeedback and biofeedback is the desire to build up a community of folks that are able to collaborate, folks that are working with each other. We kind of have a sense that, I joke about it. I say, I feel like we're kind of like the old Wild West, those of us that are in neurofeedback field, and kind of each one's doing what they're doing. And I think it's time for everybody to start talking. We want to collaborate with folks, and we want to do it in a way that elevates you, that helps people to be better at what they do, helps us all to advance the field together. So that's really what we're about with the NRBS. So that NRBS membership, that's something that you can sign up for. It's just $150 a year. You get access to exclusive educational content, reduced rates for our CE courses, free entry into our Connect Tuesday sessions. And membership also allows you to be able to promote your events, to connect with a vibrant community of professionals. And even best of all, to talk about, this is an exciting event that is coming up, is last announcement, NRBS's annual conference. So we want to invite you to join us for our 3-day annual conference. It's going to be in the heart of New York City on October 24th. So this fall, 3 days in New York City. The theme is Rethinking Paradigms, Innovative Approaches to Optimal Wellness. Our keynote speaker, Dr. Thomas Campbell, who is a co-author of the China Study, which was a very popular book, very important book on diet and understanding things about the foods we eat and the health that we have. Probably one of the most groundbreaking research studies that has been done in the field. So stay tuned for more details on that and the registration info that you'll find on our website, nrbs.org. All right. So hopefully by now we've had enough folks show up. And I just, again, want to welcome you to our webinar today, where we're going to be listening to Michael G. Holler talking to us on working with OCD using bioregulation therapy. Now, Michael Holler, he is a licensed mental health counselor, a national certified counselor, and I was chatting with him before. He said, "Oh my goodness, Michael has got a list of certifications that just goes on." It's been delightful getting to know him, to read more about him. He works actively in the community. He has a private practice down in the Florida Keys. So if I sound a little bit envious right now, it's because I'm in Connecticut and it's cold up here. But anyway, he's in the Florida Keys. He's been working with individuals, families, relationship dynamics, organizations for over 36 years. He is a neurofeedback provider. He's been involved with this for an awful long time and has worked with inpatient psychiatric situations, community mental health, private practice settings, has worked as an adjunct professor in psychology in the Florida Keys Community College. He was president of the Upper Keys Interagency Council in 1997 and was the first intensive on-site service counselor in the state of Florida. He was the past president and ethics committee chair and currently serves as the parliamentarian of the Florida Mental Health Counselors Association. And what I find really interesting too is he has written books and a number of different articles. He does work on direct and inferential model of communication, and as well is also an expert in integrating bioregulation therapy with multiple modalities, and talks about having some pretty remarkable outcomes. Now, on top of that, too, somehow, some way, this man has found time to be a musician, guitarist, and singer. Continues to do these kinds of things, and is actually, what did you say, is a former master scuba instructor, and has even written an article on the psychological aspects of dive rescue management. So, Michael, it's been kind of fun to look over all the stuff that you're involved with. I'm going to actually silence myself and hand this over to you in just a moment. Um, and I will let you know too, as well, we're hopeful that at the end, if we're able, we can maybe answer a few questions in the last 5 or 6 minutes. If you have a question, for those of you that are out there, feel free to just type it into the chat. We'll monitor that. And perhaps we can get some of those answered otherwise. But Michael, at this point, I'd love to hand it over to you. And I am very much looking forward to hearing about OCD and bioregulation therapy.
Hey, climbing out of the bowl of alphabet soup. Okay, we can get into what we're going to talk about today because my credentials are whatever they are. And in my first career, I was a musician. That's where I actually found the term. This is my second career. So today I want to talk about primarily OCD, which ironically is not the primary focus of most of my practice, but it's something that I've had really good luck with. So I wanted to kind of share that. The mother company that we're working with is Nesta Bioreg Technologies. I guess I'll have to do this with the mouse. That's okay. And so this webinar is sponsored by them, and as Jeff said, we'll be giving you more information on that as we move forward. And you've seen all my information here, so I'm not going to wade through that again. All right, so our learning objectives today is to define the words obsession and compulsion, to review standard treatment options for obsessive compulsive disorder, understand how bioregulation therapy supports neurological balance and healing in OCD treatment, examine real-life OCD case studies and observe outcomes with bioregulation therapy, learn actionable strategies for incorporating bioregulation therapy into clinical practice, and explore how to effectively integrate psychotherapy and bioregulation therapy for optimal patient care. So we're going to talk basically about some key concepts and clinical considerations. The first thing I'd like to do is I'd like to define obsession and compulsion. Now, these are my definitions. And in my model, there's easy versus difficult, and there's simple versus complicated. So when things are difficult, I like to opt for simple whenever possible. That makes sense to me. And I always tell my clients, you as the consumer should always be asking, is Michael making sense? Not, do I like what he's saying? Because I'm going to tell them what they need to hear, I think, not necessarily what they want to hear. So my definition of an obsession is a thought you cannot not think. We tend to get locked on them. That left hemisphere just starts rotating and we start to obsess and we just can't stop and it's going over and over and over again. My wife has a little bit of OCD and she calls it crosstalk. It just won't stop and it drives her kind of nuts. And it's a short drive, so she tells me. And a compulsion is a behavior you cannot not do. Okay, hence the term obsessive compulsive disorder. Now, I'm going to point out also that there are quite a few people who have obsessions but don't have compulsions. There are also quite a few people who have obsessions but not really pronounced compulsions till you start asking penetrating questions and you realize they do have some compulsions, and then they realize it. And so you can see some of these symptoms as we move forward through this page here. You'll see some symptomatology that has a lot of overlap with other diagnoses. And as my training with electrotherapy has been, we don't necessarily care so much what the diagnosis is, as we care what's going on with the brain and body functionings that are causing these symptoms that allow us to diagnose. But if you're dealing with insurance, and many of us are, you have to come up with a diagnosis or you're not going to get paid. So some of the common types of obsessions are intrusive, repetitive thoughts. They just go over and over and over again. They're very often fear-driven because obsessive compulsive disorder is an anxiety-based disorder. And they also involve catastrophic thinking, or what Julian Rotter talks about, when he talks about internal thinking, that he says a lot of our internal dialogues consist of whining, complaining, awfulizing, and catastrophizing, which is really kind of true when you think about it. And sometimes it rises to the level of paranoid ideation. And if you look at the little chart here, I found that to be pretty useful, that you've got all of these types of disorders that rotate around this type of functioning, because as I was trained, that a lot of obsessive compulsive types of stuff was caused by an under-aroused left hemisphere. And the same with ADHD, and ADHD is an area of expertise for me because I've been working with adolescents since I started. And I just noticed the number isn't 36 anymore, it's 40 years. Can't believe I'm that old. But you see here over to the left here, you've got the sensory integration disorder, which is all of those types of things like they can't filter out noise from the background. The toe seams in their socks drive them nuts. The tags in their clothes drive them nuts. Certain lights, certain sounds, busy environments drive them crazy. And that overlaps with a lot of things such as autism spectrum symptomatology. And there's a lot of anxiety that's based, I find, in ADHD quite often. So you can kind of go around this curve or this circle here and find a lot of, and I'm glad they did this with Venn diagrams, there are overlapping symptomatology here. Even gifted, once in a while I get somebody who's got an IQ that's around 165, 170. When you get that high up the ladder, very often screws start to work their way loose, and you end up with some problems there. And that we could help them with. So frequently co-occurring issues would be ADHD, anxiety, depression, autism spectrum disorders, and sensory integration challenges. And then the treatment considerations, and this is where it drives me nuts. So I'm going to red flag. I'm not a big cognitive behavioral therapy nut, okay? I find people will be ordered to me by a doctor who says, go see Michael Holler, and he is to do cognitive behavioral therapy. I don't like it when they tell me what to do, or worse yet, a judge will order somebody to me, and I'm supposed to do cognitive behavioral therapy, even if CBT isn't the appropriate treatment for this disorder. I tend to be a lot of times more, background, history, kind of, that kind of stuff, psychodynamic. So I don't always want to be trapped into CBT, but CBT can be a very useful tool, and I certainly use it all the time. Also, somatic and physiological components to address through integrated care, and that's what we're going to be talking about today. It's one of the things that I love about bioregulation therapy. So with cognitive behavioral therapy, traditionally what we've done with OCD is we throw cognitive behavioral at it. And just a real simple delineation down below here that I've thrown together with CBT. The cognitive restructuring is a big component of it, because what we're doing with CBT is we're challenging negative thoughts and trying to replace them with more realistic and balanced alternatives. How do you do that with obsessive compulsive disorder? I mean, if your left brain is under aroused and it can't get out of that loop, telling them that this is an irrational thought doesn't tend to be really useful. It's sort of like, well, you go to the doctor and the doctor says, what's wrong? And you say, well, it hurts when I do this. And the doctor says, don't do this. That's not helpful. I mean, if the doctor says that, you should run screaming from the room, but sometimes that's all we can do. And so as it says here, it's a proven approach for managing OCD symptoms, okay, by addressing thought patterns. And we're just treating the symptoms, not the disease, so to speak. And that's always been frustrating to me with OCD. We can also use behavioral experiments. We can test beliefs. Oh my God, if I say the wrong thing, I'll just die. I very often use a microphone singing a song in front of people, and I say, how would you feel if I asked you to sing a song in front of 300 people? Oh my God, I couldn't do that. Why not? Because I'd be horrible, right? Nobody dies from that. Well, yeah, that's true. And what are they going to do? Run you out of town on a rail? Because if they're going to do that, then every time you go to a karaoke session, and me as a singer, karaoke drives me nuts. Okay. And then I get up and sing and they're like, boo, you're good. So it's just weird. So karaoke to me is 3 hours of fingernails on a blackboard. But then I explain to them, nobody dies from you singing badly in front of them. They don't care. They may not like it. They might boo you, but nobody dies from that. Well, that helps a little bit, but they're still ruminating on it. And exposure therapy, where you can gradually expose them to the feared stimuli and say, okay, let's try this. I had a colleague years ago who had a person with OCD, took them to the grocery store because they were like terrified to go to the grocery store. He said, what's your worst fear? Well, my worst fear is that I'll have a panic attack here. He said, what happens if you have a panic attack? Well, I hyperventilate. And the guy said, well, you might pass out. Your greatest danger isn't the panic attack. It's falling down and hitting your head. And he said, oh my God, if I fell down, everyone would be looking at him. And my colleague said, okay. And he laid down on the floor, and his client was like, what are you doing? Oh my God, they're all looking at us. And he's like, yeah. And your point is, and it was helpful, but it didn't fix it. He still had the anxiety. The other is using relaxation techniques. We were talking earlier about breathing, teaching stress, anxiety management tools like deep breathing, box breathing, teaching people that breathing in through your left nostril turns on the parasympathetic nervous system, which is true, but you still have the obsessive thoughts going. So as soon as I start relaxing myself, I get relaxed, and then I focus back on the thoughts, and I can wind myself back up again. Not fun. Okay, so the goals of CBT is to manage the symptoms and help them cope, okay? It's also to reduce the severity of the disorder, but not get rid of it. But eliminating the disorder, I've heard that sometimes CBT can lead to full remission with little to no clinical symptoms, but I haven't seen too much of that. I'm sure it exists, but it's just not the most common outcome. We'd like to have more predictability and more frequent positive outcomes. So with OCD and neurofeedback, we can certainly calm overactive brain regions. That's very useful, targets areas such as the anterior cingulate cortex and the orbital frontal cortex to reduce hyperactivity in the thinking. Also balances the brain waves and reduces high beta, which we know produces anxiety, and increases alpha activity to relax and ease overthinking and promote mental clarity. Also to retrain neural pathways to lower anxiety and compulsions by establishing healthier brain activity patterns. Now, we want to train the brain to get into areas and functions that serve it better. And it enhances neuroplasticity, if for no other reason that it's improving the emotional regulation and getting them to believe that they can change. And that's half the battle sometimes. I like to tell this dumb joke about my job keeps me humble. I'll keep my day job. But you know how many therapists it takes to change a light bulb? Just one, but the light bulb has to really want to change. Okay, I tell that joke to keep myself humble. I will keep my day job. But it can be effective in a therapy session. Okay, so let's talk about bioregulation therapy, which is really why I'm here. what it is and why it matters. Okay, so bioregulation therapy is a non-invasive approach that combines body biofeedback with pulsed electromagnetic field technology to enhance cellular communication through the brain and body. It's based on the idea that the cells communicate with each other electrically, which we know they do. And I just finished presenting at the American Mental Health Counselors Association and the Florida Mental Health Counselors Association on electrotherapy. And I got to tell you, electrotherapy, and that includes neurofeedback, is the up-and-coming field. It really is. And there are lots of different uses. I mean, we've got transcranial um, uh, magnetic treatment now for depression and several other things. So we've got all kinds of things that are coming forward in electrotherapy. And PEMF is involved in a lot of them. And pulsed electromagnetic field therapy is totally innocuous. You don't really have any side effects to speak of. In fact, there's only one side effect that I've ever seen in bioregulation therapy, and I'll talk about that a little later. And it's pretty minor. So when we introduce bioregulation therapy, it optimizes cellular communication. It promotes unblocked, efficient communication between cells. Okay? An essential foundation for physical, emotional, and mental health. This is really good for a lot of physical ailments. It's great for pain management. I didn't have too much success with pain management with neurofeedback. Sometimes I did, but not as pronounced as this. It balances the nervous system. It's especially effective in managing anxiety. And I'm talking about, I'm getting people in the chair hooked up and getting 20 to 40% improvement within 5 to 10 minutes. That is not a real common outcome. And that just blew me away from day one. So it's promoting calm and relaxation. And that's usually what I start with. It has a rapid calming effect. So it can quickly calm the body. I think it sets up electrical interaction with the body that allows the vagus nerve to calm down. And when you can calm the vagus nerve down, it can go back into the parasympathetic nervous system and activate the calming effect. Also has a neurochemical impact. The evidence suggests that bioregulation therapy may stimulate norepinephrine production. And we know that norepinephrine is key to turning on the parasympathetic nervous system, which is what we use to recover from trauma or stress responses. So the stress response is caused by the sympathetic nervous system. So we go from sympathetic to parasympathetic, which is the goal. And to be able to happen very quickly is no small matter. So kind of just a compare and contrast here. They're complementary, as we've discussed, but the difference would be neurofeedback uses operant conditioning to retrain the brain and enhance cognitive function. We're sitting in the chair, we're hooked up to the electrodes on the skull, which are measuring brain activity, into the software. And then when we're in the right frequencies, we get rewards for that, reinforcement. It's visual and auditory, sight and sound, regardless of your system. That's pretty much the way it works. And as we do that, what happens then is we begin to train the brain. So we're Pavlov's humans in that situation, really. Now that does take some time, but it also helps calm the mind and improve emotional regulation and impulse control. Very often with neurofeedback, it can calm people down fairly quickly. I don't know about it lasting that long in early sessions. It usually takes a while. And almost all of us can get rid of a migraine in about 10 to 20 minutes. We all know how to do that. But it utilizes brain mapping to identify neurological imbalances and areas of concern. So you can kind of see on this side of it, we're really focusing, on brain functioning. Okay. And through the brain, hoping to reach the rest of the body. One of the main differences here is with bioregulation therapy, we're engaging the body's electromagnetic self-regulation system. Okay? So we're engaging the whole body, the whole nervous system, not just the brain. And, if you've read The Body Keeps the Score, which is obviously an excellent book. There's another one, trying to blank on the name of, by a cell biologist. It'll come to me in a minute here. And there's so much things in it, and it really has steered me into quantum studies more. We're getting into more of the deep stuff. So it promotes cellular communication and systemic balance throughout the body, throughout the whole body. And unlike neurofeedback, bioregulation therapy does not rely on operant conditioning. Instead, it relates directly through energy pathways. So I'm going to show you how that works here in a second. So what happens with the cell comm is we're hooking up to the entire body. And what happens is there's signal transduction. So we're taking the electrical signal directly out of the body. When we hook the person up to the cell comm, the bioregulation therapy, that device becomes part of their body's electrical system. Literally becomes part of it. There's no gap that you have with the operant conditioning. It's a direct linkage. So it receives signals from the body electrically, and it filters them. And this filtering supports the body's ability to self-regulate. But one of the things that I get as a criticism whenever I present on bioregulation therapy is they say, this sounds like a panacea. How can you do all those things? How can it do all those things? It doesn't do anything. It takes electrical information from the body and stores it in the device as data. Now, there's a difference, for example, between data and information. Data is just stored. It becomes information when you download it into something that you can use. It's sort of like a flash drive. You have a flash drive, and in that flash drive, there's data, but you can't do anything with it. It's not like the amazing Karnak where you hold it up to your head and, here's my flash drive. I'm going to hold it up to my head and it will become. No, you have to download it into information that you can use before it has any effectiveness. Otherwise, it's just a glorified paperweight. So what happens is we create a biofeedback loop. Now, unfortunately, this drawing, which is the best I could come up with, makes it look like a straight line, but it's really more like a spiral. Takes the information, puts it into the cell comm as data. Then the cell comm provides the body with pulsed electromagnetic field through a pad that looks something like this. This is one of the antennas, and this is behind it. And it's pulsing electromagnetic field from this pad through the whole body. And as it does that, it takes the information from the body, and the software then tells that we program tells it what to focus on. It then feeds that information back in the pulsed electromagnetic field and into the left wrist as body biofeedback. Those two things then allow the body to begin to self-regulate. And that self-regulation component is a really important key to this. And what happens then is that the body takes that information and it knows what to do with it. When he says the body keeps the score, he's right. So the body knows what to do, and it goes and finds areas that need to be fixed, and it activates those cells. And then the cell comm picks up the electrical information again, and it comes back through as changed information. It's like it's spiraling up. So there are iterations and iterations and iterations of feedback that spiral up, and I think that's what creates the quick response that we get. But it's very gentle. So it's a real-time feedback loop because it's directly hooked to the body, but it's a very gentle signaling output. So the feedback consists of subtle body-specific signals that evolve continuously through the loop based on the body's input. The body says, hey, I need more of this. And the regulatory status, according to this is a bit of a side note, is that the cell comm is registered with the FDA as a Class 2 biofeedback device. Now, here we have sort of a picture of what it looks like. And you can see in the gold-plated sensors on the body serve as inputs that are like microphones, metaphorically speaking, that pick up a broad spectrum of electromagnetic fields from as deep as 4 inches or more into the tissue. Well, it's picking up that electrical information. It then goes into the device, which you see on the upper left picture here, okay? And the software screen is up behind it. And you can see the plate on the left arm, which is the return body biofeedback plate. I like to call them plates rather than electrodes. When we say electrodes, our clients tend to think of Frankenstein and they get freaked out. So I just try to temper it a bit. And then you can just sit calmly in a chair. And with this woman, you can see that the device is on the floor. She's sitting in the chair. She's hooked up to it. She can read a book or do whatever she wants. They've got the pad on her stomach. And the next picture, they've got several pads, and the person is lying down. And then the other picture, they've got them pads on their stomach. A lot of times we put them behind them. And in this case, she's got some sensors on her temples. And there are some protocols, for example, bipolar. I've got a really good bipolar protocol that can take people out of mania pretty quickly. And so it would be, for example, using that. But it's a very simple setup. Doesn't take a whole lot of room, as you'll see in a minute. So how do I use it in my practice? In the first place, I never use just one device. I'm always using the Cellcom, which is the larger device that you just looked at. But also, and this is really important for OCD, I'm using the Nesta mobile unit, okay? And the Cellcom we can use once a week, maybe twice a week, depending on the protocols. But the mobile device, they can get their own mobile device and use that 5 to 6 times a day. I do that every day. And it makes a huge difference. So with the Cellcom, it's our primary in-office device, and we use that in most bioregulation therapy sessions. The Nesta mobile unit can be used both in-office and for at-home care. So when I start a protocol, I always start with 5 minutes of this. It's going to run for about 30 minutes. And then I set a timer, and in 5 minutes, I start the Cellcom. Okay? And so what that does is it sort of prepares the nervous system, gets it ready for the Cellcom's input. With clinical applications, and I'm just going to list a few here, okay? It's effective for treating anxiety, depression, ADHD, bipolar disorder, addictions, pain management, obsessive compulsive disorder, and many, many more. And the reason it's not a panacea, because people say, how can it do so many things? It doesn't actively do anything. It provides the body information. The body then does it itself. It self-regulates and self-heals. So the thing is that what can occur, I'm going to use that word, is whatever the body can achieve. That's why so many things can happen. There's no limit to that. But that's not the bioregulation therapy equipment. That's the body taking the information from the BRT device and doing what it decides to do with it. And why bioregulation therapy? For me, this is probably the single most powerful tool and useful tool I have to address the majority of concerns that I deal with in my practice. Now, you talked earlier about me living in Key Largo, which I do. Okay, nanny boo-boo, you guys. But nevertheless, sorry, I didn't mean to be rude, but I couldn't resist that. On the other hand, though, people say, oh, you live in Key Largo. That's great, but it's still a rural area. And those of you who live in rural area know what I'm talking about. My wife is a realtor, and she says that the Upper Keys is just basically Ooterville with an ocean. We still have a dearth of services. So that means that we as clinicians need to be very broad spectrum. People are always asking me when I go to conferences, what do you specialize in? I said, I don't specialize in anything, because if I did, I would starve. Now, in my older years, I'm specializing in some things. I've always worked heavily with adolescents. I've done electrotherapy. I specialize in working with couples. I'm starting a couples coaching program. I wrote my book on couples relationship theory. So there are certain things that I tend to specialize in, but I do pretty much everything. And you kind of have to. Now, this is the Cellcom. This is my office, okay? And on the left, you see basically my counseling area, which is behind me right over here. And that's where I meet with clients, and we do the talk therapy or whatever it is we're going to do. On the other corner, which is over here, it's just a corner of my office. You can kind of see the computer over my shoulder. That is the setup in the middle. That's my bioregulation therapy setup. It doesn't have a really large footprint. I've got it in a corner of my office. And then the next picture is my wife. Isn't she cute? Doing her protocol. I just love her. Anyway, it's a good thing, because she's Sicilian. When they get mad, they get out the knives. So if I didn't love her, I could be dead. She'll laugh when she sees this. But you see that little table behind her over her right shoulder? That's pretty much the entire Cellcom setup right there. It occupies about a 1.5 foot by 2 foot table. It's very easy to deal with. Does not take up a whole lot of room. And you can kind of see, if you trace the wires, that the typical applications, and that one is as I said, she has OCD, so this is her OCD setup. But the typical presentation wouldn't necessarily be on the temples, but it would be right wrist, inside of both ankles, sternum, umbilicus right on the belly button, and then sometimes sternum and umbilicus are replaced with the temples. Okay, so you have a lot of different kinds of applications that you can do, but it does not take up a lot of your office, which I'm grateful for, because it makes it easier for me to deal with. Okay, now here's what the software looks like, and I'm not going to get too much into this because it isn't going to make a whole lot of sense until you get walked through it. But that's what Tarul can do if you want to do a demonstration. He can show you how this is. But you can see on the left here, you've got, and this is in particular in the OCD protocols, and we've got several, and I would just go through these each session. It's kind of dummy proof, which is part of the beauty of it. You can start using it immediately. And we have regular training, so we ethically aren't supposed to do anything we're not trained to do, but we continue. And then the training is, for the most part, free. And it's not rocket science as far as its complexity when you're doing the training. But you've got the up here in the center section. It tells you where to put the sensors. Okay, it gives you sometimes an alternative, and then below it has notes saying this is what you might want to do. This is how often you might want to do it. Okay. And then on the right here, you've got the what are called programs. Inside each protocol, like you see over here on the left, you've got OCD1, and that's what's over to the right here. You have various different what we call programs. And you'll see that the first one's 4 minutes and 28 seconds. The second one is a pause for 3 minutes and 30 seconds. The fourth one is for inflammation, and we have 428, and then we have another pause. And we have to have pauses because as the device gives the body the information that the body makes changes, it needs to pause to recover in between. And those are woven into protocols. And then at the end of the time, it will go, and it'll tell you that it's done and you're ready to go. Now, I told you there's one possible negative side effect. When a person goes through a protocol, the body is changing a lot of things in its function. And the body system is going to have to get rid of some of the metabolic waste that occurs as it rearranges anatomically. And so the lymph system is going to dump metabolic waste into the body. And the body then needs to flush that out. So the only thing that can generally go wrong is you want them to drink some water when they're done to help flush that out. And if they don't drink the water, they might get a headache. We're not talking a migraine, we're talking a headache. So pretty easy cure. So I always keep water there, and I always give them water afterwards. Just don't want them to get a headache. But in 2 years, I've only ever seen that happen once. So I'm pretty happy with that result. Okay. Case studies, looking at my time here. I hope I can we don't have to get through all of these, but I'll try to rip through them as quickly as possible because I want you to have the ability to ask questions. And I hope I'm being thorough enough that it makes sense. OCD case study 1. This was the one that really blew me away. This is the first one I managed to get rid of OCD in. Excuse me. It was a 17-year-old male. He had extreme obsessive thoughts. They were driving him crazy. And he had numerous rituals that he had to do, like tapping the doorknob 3 times. And when he was driving the car, he had to adjust the rearview mirror 4 times and wipe his hands 3 times. I mean, he had all kinds of, they were small things, but they drove him nuts. And he also said, whenever I get the troubling thoughts, I get severe acid reflux. So I almost always start this way. I started the weekly CellCom BRT sessions with multiple targeted anxiety protocols. That's just kind of a standard format. The initial treatment began with one foundational protocol. Now, the beauty of the foundational protocol is twofold. One, it gets them calmed down, or threefold really. Gets them calmed down, gets them acquainted with the process, and the other thing is it has a very calming effect on the entire body. You can just watch the person sit in the chair and go, okay? And the most common comment I hear after the foundation protocol is, I feel like I just had a glass of wine. Not the drunk part, just the calm part. And the measurement in this, and this is a big thing, people say, what does it measure? The CellCom does not measure anything. What does it do? It does not actively do anything, okay? And so what happens is I'll ask him, and this is my primary measurement. I'll say, what are you dealing with here? In his case, it was the obsession, the anxiety, and the compulsion to do rituals, all right? And so I said, put all that into a lump, or you can put it in 3 different sets, 0 to 10, standard measurement. 10 being the worst. Okay, 0 being nothing. And he said, I'm a 15. Okay, it wasn't a surprise to me. All right. And the other thing that's cool about this is he's sitting in the chair doing the CellCom session, and I'm doing a psychotherapy session while I'm doing it. I couldn't do that with neurofeedback. It would interfere. Okay. But I can conduct a full psychotherapy session while I do a BRT session. Okay. And so I said, so you were a 15. 2 minutes in, I said, what's your number? He said 10. Like, oh, well, all right. That's about a 40% improvement. We continued to talk. 2 minutes later, I said, what's your number? He said, it's a 7. 5 minutes later, what's your number? He said, it's a 3. By the time we were done, he was at 2. He said, I haven't had this amount of calm with no anxiety since I was 5 years old. And that sells the system. It makes them want to come back. They feel better after the first session. They're getting results in minutes, and the results tend to stick. So his particular results at the 2 lasted for 4 days. Now, I loved my neurofeedback system, but I rarely got positive improvement to that extent in the first session. It usually took 10 to 15 sessions before I got pretty significant results. And I almost never got results with the exception of sometimes anxiety in the moment or a migraine. I rarely got positive results really, really that quickly. And I think the thing that makes it work a little slower is the operant conditioning. I don't know that for sure, but that's what I think. So we did the weekly CellCom sessions. We did the initial treatment with foundation. I progressed to 11 specialized anxiety OCD protocols. And he got his own mobile BRT device, the Nesta mobile unit. Okay. He got one of his own, took it home. They can sell it to you. They can lease it. And he used it 5 to 6 times daily. After that period of time, the obsessive thoughts were completely resolved. He didn't have them anymore. His ritual behaviors gone, and the acid reflux symptoms were eliminated. I've never seen that happen before with any treatment. And this was my first. And what I've noticed, and I think one of the key components was the use of both devices. He was using this daily. Of all the people that I've been able to get rid of OCD, they all had their own Nesta mobile unit. Okay. And the other people that didn't get the Nesta mobile unit, I could reduce the symptoms, but I couldn't get rid of it. Now the OCD case study, and this one is interesting. I use this with couples. I was talking to Jeff about this earlier because I specialize a lot in working with couples. And any of you who work with couples and you study, for example, Gottman's information, Gottman has, in his research, has noticed that when couples are in high conflict in that moment, their heart rate tends to be above 100 beats per minute. Okay. And very often, if you can get them into another room and just have them, what he did was have them read a magazine and then bring them back, their heart rate is back down again. And that tends to kill the anger and the high conflict. So this was a 35 and 34-year-old heterosexual couple. The wife had been diagnosed with ADHD and obsessive compulsive disorder. The husband, in his wisdom, had a one-night stand, realizing he was an idiot, told her about it and apologized and was begging her for forgiveness, but she locked onto that thing and could not let it go, and leading to a severe relationship distress. So now she associates him with her anxiety. And she became fixated on the affair, and I came up with a term I came up with it myself. You've heard about trauma bonding, where people will bond to somebody that really don't have anything in common with because they both have a common trauma. Well, in this case, she was bonded to the trauma. She was more bonded to the trauma than she was to him at that point. And so that kept the relationship continuing to be marked by high volatility and conflict. And it was really hard for me to get them to ratchet back down. Because all she could think about when she looked at him was you had an affair. Okay. And that was basically his middle name became, let's make his name Steve Jones. He became Steve, you had an affair Jones. And that's who she thought of him as, and she could not let go of that. So what I did was I took her and I put her in the chair. She agreed to do this, and I discussed it with her ahead of time. We did weekly CellCom BRT sessions, again, multiple targeted anxiety protocols, one foundation protocol. So I did a couple session with her while she was doing a foundation protocol. And, I did the same thing. What's your number? And she said, oh, it's a 12. I'm a 12 on a 0 to 10. And there are two ways that I measure this now. I'm going to share this with you in a second. So we began with the one foundation. In 2 minutes, her 12 was down to 8. In 10 minutes, her 8 was down to 4. By the end of the session, she was down to a 2. It wasn't gone, but it was significantly reduced. Okay. And now she's sold. Okay, let me do this again. And I feel good. And this helps. And I said, now also, because we're talking about the difficulties in your relationship, I'm asking you, what's your number, 0 to 10? But I'm also asking you, what would you expect your number to be based on what we're talking about? So when she was at 5, she said, well, I'm at a 5, but based on what we're talking about, I would expect it to be jumped up to a 20. So it helped keep her parasympathetic nervous system engaged so that she could stay calmer during the sessions. And she's now beginning to associate her husband and interacting with him in a more positive way. And so we're back at operant conditioning. So this advanced to 11 specialized OCD protocols, and she used the mobile device 5 to 6 times a day at home. By the end of the time, she reported no more obsessive thoughts. She didn't come in to deal with her obsessive compulsive disorder. She came in to deal with her couple's issues over the affair. I just noticed the OCD as part of the constellation. There was a significant result in a reduction in anxiety and mood swings. The couple is now experiencing improved communication in negotiation, and there was a notable decrease in marital conflict. They're doing a whole lot better now. I'm done with them. Their marriage is intact, and she doesn't dwell on the affair anymore. 18-year-old female, the high school senior, competitive soccer player, experienced severe obsessive fears about using public restrooms. And it got worse and worse and worse to the point where she couldn't leave the house anymore. She had obsessive thoughts that included fear that every time she went to a public restroom, others were judging and talking about her while she was in the restroom. And they were talking about what she was doing in the restroom. She just couldn't let this thing go. And she also displayed these elements of paranoid ideation. And the symptoms led to school avoidance. She wouldn't go to school anymore, and risk of not graduating and losing a very lucrative college scholarship. She had a full ride. We began with one foundation protocol. I almost always start with that. Administered 10 targeted CellCom BRT anxiety OCD protocols, and she was using the mobile device at home, and ongoing application of multiple anxiety protocols. At the end, obsessive thoughts were completely eliminated, paranoid thinking completely resolved, fully resumed public activities and school attendance, and no longer at risk of losing her scholarship or graduation. I'm going to tell you, when I started working with this system, I did not expect any of this. I have never had results like this with OCD at all. I don't specialize in OCD, but I'm kind of like getting dragged kicking and screaming by my left hind leg into it, I guess, but here we are. If you want to learn more, you've got this, and I'm happy to answer any questions that you have.
Fantastic. Thank you, Michael. This has been amazing. A lot of good learning so far. We have a couple of questions that have come through.
The answer is 4.
One,
I'm sure the answer is 4.
one of them is, how long does PEMF last? And I'm thinking also we can look at that in terms of kind of the short term and the long term.
Yeah, and that's a good question. In those initial first couple of sessions, it tends to last anywhere from a very minimum of 2 days. More frequently, it's 4 to 6 days after the first session. But when we get like 7 sessions in, they get their results, and by the time they get here, if they're waning at all, it's gone from, if I'm going to measure a positive scale of their results of 10, by the time they come back for the next session, it's at 7. Which means I got a leg up when they walk in the door. It's like a head start in the race,
Excellent. All right. Another question. Can you use BRT to treat misophonia?
Wow. Being a musician, somebody's afraid of music? Is that
Well, misophonia, Yeah, that is a severe reaction to certain sounds, things that can drive you to rage, anger. If you,
Yes.
for instance, hearing somebody chew.
Absolutely. It's those are sensory integration issues, and those are all caused by an over aroused right hemisphere. That's typically how I would treat them with neurofeedback. But it works. The BRT I find works much faster and much more pervasively. So those overload kinds of things. It's not just usually the sounds. It's lights. I've learned to ask the questions. Certain lights they hate, certain sounds they hate, certain textures or feel cloth, certain textures of food, certain sounds like rubbing styrofoam together is real common. Chewing. The toe seam in the socks, they can feel that toe seam all day long. They can't stand tags in their clothes at all. And when they're in busy environments, they have to get out of there. It overloads them. And the other thing I've learned to ask is when you're in a restaurant, like say on a date, can you take all of the conversations in the background and fade them into the background so you don't really hear them and just hear the person across the table? Or do they all come in equally, like drinking from a fire hose? And they usually express all of those. So yeah, it's really effective for that.
Nice. It's also a question about BRT and the linkage between OCD and pans and pandas. Do you have any experience, or can you comment on the use of BRT in that
I
context?
have, but based on the knowledge and training that I have with regard to physical stuff, pandas, I had my poor colleague I used to share my office with treated a couple of people with pandas using using neurofeedback, and she got some pretty good results with it. But most physical type of ailment stuff that we deal with BRT is very, very responsive.
Nice.
Yeah. And if I may add,
Does it help with pain? Go ahead.
no, I was just saying that there are specific protocols for pans and pandas. I was just saying there are specific protocols for pans and pandas as well in the system.
He's right, there are. But the other thing is that it's a biologically based problem, and the body can fix itself most of the time with most conditions. I mean, Dr. Gabor is having people coming back from advanced Alzheimer's to perfect functionality intellectually.
Nice. Now, are there training resources for learning how to use the equipment?
Well, we provide those training resources. This system is very commonly used in Europe. I mean, it's all over the place. And of course, we Americans, as usual, are behind. The company, when they, and I don't want to get ahead of Tyrrell here, but when you buy the system, they provide you with some training. And that's why I'm sort of the clinical consultant. So very often what will happen is you would go and get some nuts and bolts training, how to operate the system, how to set it up and use it. And then I would work with people for several sessions for clinical. And then we have ongoing training sessions at least once a week and regular webinars. So there's a plethora of training available.
So, question is, how would you explain the norepinephrine being an excitatory neurotransmitter, fight or flight response, shifting sympathetic to parasympathetic symptom prevalence? It's kind of contradictory.
Okay, not unless there's a typo there. Norepinephrine, in my experience, isn't excitatory. It's calmatory. If I can coin a word. The sympathetic nervous system is activated when we perceive a threat. Ask me what time it is. I'll tell you how to make a watch. We have to perceive a threat. It doesn't actually have to be a threat. A good example of that would be asking somebody to get up in front of a microphone and sing a song. That's not an actual threat, but a person perceives it as a threat, then they'll be traumatized by it. But in order to, because that's caused by the adrenal glands dumping epinephrine into the system, okay? And people will ask me, well, what happens to the epinephrine? Do we pee it out? Do we metabolize it? Do we burn it? No, it sits there and keeps pulling all the stress hormones into the system and creating damage until we perceive that the threat is resolved. That's the important key factor here is we need to perceive that the threat is resolved, whatever it takes for that to happen. Once we perceive that the threat is resolved, then that turns on the parasympathetic nervous system, which calms us down. So if somehow I got in the slides that it was that I perceived the norepinephrine as an excitatory neurotransmitter, I don't. Quite the opposite. But we also know that inhaling through the left nostril, that's why box breathing works. Inhaling through the left nostril specifically You don't have to close the other one, but that's the one that triggers the parasympathetic nervous system to kick in. But we really need that perception of a threat, and that's why I asked the questions: what is your number? Can you see the improvement? What would you expect your number to be at if we were based on what we're talking about? And they're saying, well, I would expect it to be much worse. Well, that's reinforcing their perception that this is helping them resolve the threat, when really it's their own body doing it.
Good. All right. With that, I think we're going to need to wrap up. Michael, thank you so much for this. And please keep in mind as well, you'll see in the chat that we can continue this conversation with NRBS board member Dr. Saul Rosenthal on our NRBS podcast. This has been wonderful. I genuinely appreciate, Michael, your willingness to share this. Very much myself, looking forward to Tarul, looking through the website, exploring more about how this can complement what we do up here. I hope everyone else takes advantage of this opportunity and looks further. So
Thank you for having us.
Fantastic. So thank you so much. Everyone have a great day. We'll look forward to seeing you all in the future.